Welcome to this rapid-fire explainer on medical board prep, high-yield MCQs. We've got a lot of ground to cover, so we're jumping right into the material.
Okay, let's dive into this. Question number 1.
A 29-year-old patient presents with generalized weakness and dizziness. Hemoglobin is 8 grams per deciliter. MCV is 111 femtoliters. Platelets are normal, and total leukocyte count is normal. Most probable diagnosis? Option A, autoimmune anemia. B, megaloblastic anemia. C, iron deficiency anemia. D, sideroblastic anemia. Or E, aplastic anemia. The correct answer is B, megaloblastic anemia.
So, the crucial point here is the patient has anemia with an MCV greater than 100 femtoliters, which points us right to macrocytic anemia. The most important causes you need to know are vitamin B12 and folate deficiency, collectively called megaloblastic anemia. Note that iron deficiency and sideroblastic anemia, those are microcytic. For your exam pearls, keep these numbers locked in. An MCV less than 80 is microcytic, 80 to 100 is normocytic, and greater than 100 is macrocytic. Remember, iron deficiency anemia is literally the commonest microcytic anemia. Sideroblastic is also microcytic, and aplastic anemia usually presents as pancytopenia.
Next up, colloids are used in shock because of A, decreased pulmonary complications than crystalloids. B, better renal perfusion than crystalloids. C, superior outcomes to crystalloids. D, retain hemodynamic stability. Or E, greater infusion volumes are required with colloids. The correct answer is D, retain hemodynamic stability.
So here's why. Colloids remain within the intravascular compartment for much longer periods, and therefore they maintain hemodynamic stability with smaller infused volumes. But it's worth noting they haven't actually shown superiority over crystalloids regarding mortality or organ failure. Let's look at your exam pearls for this. Crystalloids are definitely preferred for initial resuscitation. Colloids require less volume to maintain intravascular volume, whereas crystalloids might require up to 6 to 8 times greater volume. And finally, albumin should generally be avoided during the first 12 to 24 hours after major burns.
Moving right along, a patient undergoing elective surgery develops excessive intraoperative bleeding despite normal platelet count, PT and APTT. Most likely pathology: A, platelet dysfunction. B, hypothermic coagulopathy. C, von Willebrand disease. D, vitamin K deficiency. Or E, hemophilia. The correct answer is A, platelet dysfunction.
Now, what's really interesting about this one is how a normal platelet count combined with a normal PT and APTT, but still accompanied by excessive bleeding, points directly to a qualitative platelet defect. Basically, the problem is in the platelet function itself, not the numbers or the coagulation factors. Your high-yield exam pearls are normal PT plus normal APTT plus bleeding. You should immediately think platelet dysfunction. Glanzmann thrombocythemia is a GPIB/3A deficiency. Bernard-Sulzer syndrome is a GP1B deficiency. Aspirin causes a platelet aggregation defect, and uremia causes qualitative platelet dysfunction.
Okay, next question. Which of the following is associated with increased bleeding time? A, renal failure. B, scurvy. C, Bernard-Sulzer disease. D, storage pool disease. Or E, all of the above. The correct answer is E, all of the above.
So, bleeding time directly reflects platelet and vascular function. Things like renal failure, scurvy, Bernard-Sulzer syndrome, and storage pool disease all impair primary hemostasis and therefore prolong bleeding time. Let's hit those exam pearls. Bernard-Sulzer syndrome is a GPYB adhesion defect. Glanzmann thrombocythemia is a GPIIB/3A aggregation defect. Von Willebrand disease is a platelet adhesion defect. Uremia prolongs bleeding time due to platelet dysfunction. Scurvy actually causes vascular fragility from defective collagen synthesis. And of course, thrombocytopenia prolongs bleeding time.
Let's keep the momentum going. A 21-year-old female presents with epistaxis, menorrhagia, and purpuric rash. Most likely diagnosis: A, disseminated intravascular coagulation. B, Henrich-Schönlein purpura. C, idiopathic thrombocytopenic purpura. D, hemophilia A. Or E, none of the above. The correct answer is C, idiopathic thrombocytopenic purpura.
ITP commonly affects young women and presents with mucocutaneous bleeding, things like epistaxis, menorrhagia, petechia, and purpura.
It's caused by IgG autoantibodies against platelet membrane glycoproteins. Here are the exam pearls you need to memorize. ITP is the most common cause of thrombocytopenia in adults, typically presenting in females aged 20 to 40 years. The autoantibodies target GPIB/III receptors. The platelet count is decreased, bleeding time is increased, but PT and APTT are normal. A peripheral smear will show megathrombocytes, and a splenectomy is your definitive treatment option. Next up, what should be the rate of fluid administration for a fluid challenge in hypovolemic shock? A. 50 milliliters per kilogram in 30 to 60 minutes. B. 50 milliliters per kilogram in 15 to 30 minutes. C. 30 milliliters per kilogram in 30 to 60 minutes. D. 30 milliliters per kilogram in 5 to 30 minutes. Or E. 20 milliliters per kilogram in 60 minutes. The correct answer is D. 30 milliliters per kilogram in 5 to 30 minutes.
The rationale here is that initial resuscitation of hypovolemic shock absolutely requires rapid administration of crystalloids. You want to give approximately 30 milliliters per kilogram rapidly over 5 to 30 minutes as a fluid challenge, just to assess their fluid responsiveness. Your rapid-fire exam pearls. The initial fluid of choice is warmed crystalloids. For adults, you're looking at approximately a 2-liter initial bolus. For children, it's a 20 milliliter per kilogram bolus. And remember, early aggressive resuscitation is absolutely essential.
Next question. A patient with hypotension due to septic shock should receive A. 30 milliliters per kilogram in 15 to 30 minutes. B. 30 milliliters per kilogram in 30 to 60 minutes. C. 20 milliliters per kilogram in 30 to 60 minutes. D. 50 milliliters per kilogram in 40 to 60 minutes. Or E. None of the above. The correct answer is A. 30 milliliters per kilogram in 15 to 30 minutes.
And this brilliantly illustrates the current sepsis guidelines, which recommend administration of 30 milliliters per kilogram crystalloid rapidly during the first hour in patients with septic shock and hypotension. Exam pearls. Septic shock is a medical emergency. You need to start that 30 milliliters per kilogram crystalloid treatment immediately. Also, keep an eye out for elevated lactate, as it suggests tissue hypoperfusion. Early fluid resuscitation consistently improves patient outcomes.
Moving to the next one. A patient with DIC and hypofibrinogenemia should receive A. Cryoprecipitate, B. Whole blood, C. Desmopressin, D. Fresh frozen plasma, or E. Packed red blood cells. The correct answer is A. Cryoprecipitate.
So cryoprecipitate is highly rich in fibrinogen, and it's used specifically when DIC is associated with significant hypofibrinogenemia. It rapidly replenishes those depleted fibrinogen stores. Examples to take away. DIC causes heavy consumption of clotting factors. This leads to decreased fibrinogen levels, prolonged PT and APTT, and a typically elevated D-dimer.
Next question. Laboratory findings. Platelet count is normal. Bleeding time is increased. PT and APT are increased. D-dimer is negative. FTP is positive. Diagnosis: A. Hemophilia A. B. Disseminated intravascular coagulation. C. Primary fibrinolysis. D. Von Willebrand's disease. Or E. Hemophilia B. The correct answer is C. Primary fibrinolysis.
So what's going on here? Excess plasmin activity causes the degradation of fibrinogen and coagulation factors, leading to prolonged PT and APTT. FTPs are elevated, but the D-dimer remains negative because no cross-linked fibrin thrombi are actually formed. Key exam pearls. Primary fibrinolysis is defined by excessive plasmin activity. FTPs are positive, D-dimer is negative, PT and APT are prolonged, and the platelet count is usually normal. It differs heavily from DIC, which has an elevated D-dimer and thrombocytopenia.
Next up, which solution is commonly used for storage of blood? A. Acidified citrate dextrose. B. Citrate phosphate dextrose, or CPD. C. CPD adenine. D. Dextran. Or E. Citrate. The correct answer is B. Citrate phosphate dextrose.
Historically, CPD was the most commonly used blood preservative solution. Now, while modern blood banking commonly uses SAGAM solutions, CPD still remains the classic examination answer. Your exam pearls for this? CPD is the classic blood storage solution where citrate acts as an anticoagulant. The modern preservative is SAGAM, which stands for saline, adenine, glucose, and mannitol. These blood preservatives maintain red blood cell viability during storage.
We've covered a lot of ground in rapid fire today. Given these fast-paced presentations and high-yield pearls,
How will you systematically differentiate between a quantitative and qualitative platelet defect on your next exam? Lock these facts in, trust the details, and good luck on the boards.